vision. So what will be your initial thoughts? Always ask for the mic and speak in the mic.
New onset squint child has developed.
Okay, new onset squint child has developed.
There
Okay.
may be cranial nerve entrapment, some lesion with the cranial nerves.
Okay, so it could be a lesion of the cranial nerve. So one further questions are which cranial nerve and where in the cranial nerve? Mike.
Looks like right lateral rectus palsy, deviation of eye to right eye to left side. No, so right lateral rectus palsy. So sixth nerve is one, uh, but blurring of vision. It could that blurring of vision could be actually diplopia.
Sir is asking UMN or LMN.
LMN.
Why? Anybody can answer why this is LMN?
Only sixth nerve is involved, so probably it could be LMN lesion.
Okay. And I think for most nerves, there is bilateral UMN innervation, except in that facial, we have that division of upper and lower. So therefore, you don't get usually a UMN paralysis of any of the other nerves.
Also, the sixth and seventh nerve nuclei are very close to each other. So what you said is very right. So if in an isolated sixth nerve without seventh, more likely to be LMN only and not a human. And as Dr. Rajesh said, bilateral innervation.
The child is unable to open the eye and a child is unable to close the eye. What is the difference? Can't open. UMN? LMM.
Able to open means there would be tosses or
That means there will be
tosses.
ptosis. What happens in lower motor neuron palsy when the patient is asked to close the eye?
Unable to close. When
Instead of closing the eye, he looks up because he wants to close the eye. He is unable to close the eye. So he gets that effect by taking the eye up as if.
Bell's phenomenon.
Yeah.
So you said acute onset squint, probably due to right sixth nerve. So why blurring?
So it could be diplopia actually. That is interpreted as blurring of vision, not primarily eye pathology.
So what is the difference between diplopia and blurring to you as a doctor? And if it is genuine blurring, then what does it signify? Anatomically, what will it mean to you?
Optic nerve involvement.
Optic nerve involvement. Okay. So can you expand on that?
But in the visual acuity.
Very good. So one reason for blurring is visual acuity. Any other reasons anatomically?
Local eye problems associated with
Very good. Like?
uveitis. So
very good. So uveitis, corneal edema, corneal injury, all these will cause blurring of vision, right? And a decrease in visual acuity.
What will happen if the center is affected in the brain? in the pathways you told us the pathway up to the, but suppose the center is affected, then what will be the position of the vision? He has blurring of vision, and you said that it is because of diplopia, etc. But this is all right, but there is a problem at the central level, occipital level. The occipital, the visual center in the occipital area is affected. Then what will happen?
Ga- gaze palsy. Uh,
He'll be able to see.
No, sir, vision, only macular vision will be spared. Otherwise you won't be able to see.
Only macular vision will be affected.
Will be
Other
spared,
will-
sir.
Okay. Is there anything like cortical blindness? Can there be a cortical blindness, or will there be agnosia, that means able to see but he is not able to narrate the meaning of all that? Since we are at the pathway of second, third, that is why I'm asking you.
So just like we say auditory inattention, there is visual inattention, which is when the association areas are involved. So from the visual center, the impulses are going to association areas. If those are affected, then what Kare is saying, that you can see, but you cannot interpret the meaning of what you are seeing. So that is visual inattention. But
The cortical center is affected significantly, there will be no vision seen. Even if he is able to see, there is no interpretation that is happening. For example, suppose a child has occipital lobe epilepsy and they have a seizure, and he says, there's darkness in front of my eyes. I'm not able to see that. Okay. So this is just by the way, since we were at the tracing of the path.
okay, now
But that's all involving second nerve, and here we are concentrating on sixth nerve.
Now, the next complaint is child is not able to walk smoothly, frequent falls, and then not associated with difficulty in getting up from supine or sitting position, and child was able to feel the ground. So, what does this mean to you? What does it mean? So, when you get any history of frequent falls, where could the problem be?
Cerebellum,
One is cerebellum, second,
basal ganglia,
okay, third,
Vestibular system.
vestibular system, yes, where else?
The motor system also can have frequent falls.
Absolutely, motor system. So tone and power. Okay. So tone, power, incoordination, everything. In incoordination, you got cerebellar, you got vestibular, all that. And where else? Frequent falls.
The vision when affected.
Very good. So special senses, so visual. So by this history that she has given, she is trying to tell us that there is nothing wrong with the motor system, because getting up, etc. is okay. So power seems to be okay. Child has also got proprioception sense, feeling the ground, etc. So no peripheral neuropathy. So this is probably related to vision, right? That's what we are saying. Now, if it is related to vision, is it affecting both eyes, one eye? Why is he falling? Why is she falling? What do you think?
She's not able to maintain her balance. There is other component other than her vision also.
So the point is that if it was only due to vision, apparently this is only in one eye. So that alone doesn't really explain the falling. So there has to be something beyond that. That's the point. Okay, then child developed deviation of mouth to left side.
So vision is not the problem because, as he said, one eye can see. And if the child is not able to see, he'll not make an effort to walk because he knows that he cannot. Can there be another cause? What is one of the frequent causes of vomiting? Causes of frequent falls? Can there be anything wrong with the motor system which is not so severe as to which the child is not able to get up or not even stand?
So they said power, tone, and then coordination. So ataxia.
So ataxia isn't there. Tone, and if he's able to stand, that means the tone and power are not affected to the extent that they can support a weight against gravity. Can there be some part affected more than that, which will produce frequent falls?
So, sir, ataxia is there or not there, we are not sure because she can get up from supine and sitting position. So, power is normal.
And ataxia,
Mostly
we don't
tone
know.
is normal, but ataxia could still be there.
Means if you ask the history whether he's swinging on standing, yes, and even sitting, while sitting is leaking, then you can say that that is truncal ataxia and standing ataxia. Is there anything else which may be related to power mildly affected in a patient of frequent fall? If I have a foot drop, what will happen to me? Will I fall frequently? No.
Yes, sir,
Because
but there the gait will also be affected, right? Mother will notice.
yes, gait will be affected only when there's a significant loss of power and tone. But if I have some weakness in the form of dorsiflexus of the foot, then my toes will touch the ground first and I will have frequent falls. You know, one of the important presentation of a child with Duchenne is frequent fall because of a small foot drop. Our heel must touch the ground first. And if our toes touch the ground first, we have frequent falls. I mean, he has no inability to walk like absolute loss of power. He can walk, but something is coming in the way due to which one. That is also one of the things we will keep in mind. So then it is weakness apart from the other things.
I think when you said there is a sixth nerve palsy, first try to assess whether it is a true sixth nerve or a pseudo palsy. What is pseudo sixth nerve palsy? Not a lesion of a sixth nerve, but still behaving like a sixth nerve palsy. And that suggests increased intracranial tension as a non-localizing sign, which is very common. Even third can come in sometimes, but sixth is very common. So first, you would have asked at that time whether there has been headache, vomiting, etc. If not, it's a true sixth nerve palsy. Isolated sixth nerve palsy, he already made a mention that sixth and seventh are so close together. Therefore, we are looking for any subtle seventh nerve. And if that is so, then they come out of the cerebellopontine angle, and therefore cerebellum or the pontine lesion also would come up. And what is cerebellum? Ataxia. And what is pontine lesion? Pyramidal tract. The moment you got 6, you got probably also 7, yet not known. And then you look at also cerebellum and the pyramidal tract, which is stone we are talking about. So straight away we go by that, right? And if you go that way, your cause of falling down is only cerebellum and nothing else.
So immediately after,
Some minor point, but interesting. You've given nice history, so I'm elaborating on that. You said child is not able to walk smoothly, but has frequent falls. Okay. So if you say one eye is normal, with two eyes there is diplopia. So if you actually close one eye, you will be able to perform better. lose when you use one eye versus two eyes, both eyes?
So, sir, if there is condition of one eye having diplopia, so in that condition, if we cover the eye which is normal, then that diplopic eye will take central position, and so that is like non-paralytic.
I will rephrase my question. What is the difference between monoocular vision and binocular vision? It's a simpler question. And then I'll come back to your one eye diplopia point. That's slightly different. So the biggest challenge is, of course, the field of vision, which is not so important, but the depth perception. You require both eyes. So if you are trying to thread a needle, that's why we close it so that you can do it easier. But when you're walking, you want to perceive the depth, both eyes are important. And when you say one eye diplopia, usually if there is a monoocular diplopia, means if you close the normal eye, even with one eye, you are able to see two things. And usually the causes are local there. So if there is a scarring of the cornea, or if there is sometimes even when they are faking, malingering, then you have unilocular diplopia. Okay. But here what I was trying to emphasize is, he was able to, if the child was able to walk smoothly and frequent falls, you could attribute it to diplopia, because the diplopia in sixth nerve will be only in a particular position. Okay. When this eye is not able to go there, when I look there is diplopia on the side of the lesion. When I'm not looking at the side of the lesion, there is no diplopia. So there could be frequent falls, but not continuous falls. That is what I'm trying to explain. But if I was not able to walk smoothly itself, then the diplopia alone cannot be the reason. That's the minor difference between the two.
Perfect. And actually, as he said, she's 7-year-old. So a bigger child will quickly perceive that by closing that eye and closing the affected eye, then there is no diplopia. So then there won't be so many falls.
And if you know right from infancy, if there is diplopia, children tend to develop a head tilt and try to negate that diplopia. So similarly, they try to find the best position of vision and they manage.
So now, as Amdekar sir said, soon this child developed deviation of mouth to left side. And there was inability to close right eye completely when the child slept. So what does this mean now? What does this mean? This complaint means what?
Lower motor neuron function, facial nerve. Left side.
Right side.
Right eye.
Correct, right side. So now you've got right sixth nerve, you've got right seventh nerve, you've got frequent falls which are probably not related only to vision, which means there could be some ataxia. And then there is history of decreased activity in the form of increased sleepiness and playfulness. So now what does this mean? What would you think? What would this mean?
Sensorium is getting affected.
What are the possible reasons? Why is it getting affected on this background? So sir just mentioned no raised
Raised
ICP. So you'll have to investigate with more questioning whether there's any other evidence of raised ICP which is doing this, right?
Later on, she developed vomiting.
Yeah. So later on she developed vomiting, right? Okay. Fine. All this is negative.
What other history that you would want to ask here? Family history, have you mentioned? I could not see the family history.
Last line.
Last line. Can I see? Last line usually
No history.
okay, similar complaints in the family. Why did you ask that? Routine, checklist. That's fine. Checklists are good.
Hypercholesterolemia,
Okay.
Marfan's.
Okay.
Usually homocystinuria comes with such.
What is the angle? Which is the location of this lesion?
This lesion, sir, sixth and seventh nerve is involved. So
And
pontomedullary,
cerebellopontine, right?
cerebellar signs are present. So cerebellopontine.
And what kind of problem that we are thinking of pathology wise?
Pathology is
So like medulloblastomas, CP angle, schwannomas.
Schwannomas. Where do you get schwannomas?
Neurofibromatosis.
Neurofibromatosis. Okay. So I'm not saying this is schwannoma and I'm not saying this is NF1, but in the history, you can make a mention that if somebody had a family history of neurofibromatosis, then that would become important because then your differential diagnosis would go more in favor of that.
No history of convulsion, disorientation. Past history is not significant. ANC history is uneventful. She was born full term, normal vaginal delivery, cried immediately after birth. Birth weight was 2.5 kg, no NICU stay or neonatal jaundice. Immunized till 5 years. Developmentally normal, goes to second standard. There's the dietary deficiency, calorie deficiency of 2300, deficiency of 8000. 800 kilocalories, protein of 7 gram. Sorry. She belongs to lower socioeconomic class. Impression: 7-year-old girl with a deviation of eyes suggesting left right rectus palsy and facial nerve palsy with difficulty in maintaining balance is a case of acute onset lesion involving cerebellum. Like we said, cerebellopontine lesion. We have a
So one sec. So when you summarize, no, instead of repeating the original complaint, you could give the interpretation. So when you summarize, you say that, go back, you say that 7-year-old totally normal child or developmentally normal girl comes with a acute onset of multiple cranial nerve palsies or sixth and symptoms and signs suggestive of cranial nerve palsies in a short duration with, so you have to talk of all your interpretation. So you got 6 now, you got 7 now, you got possible cerebellum on history, and it is a afebrile condition, so non-infective condition, right? So all this word should come in your summary, and therefore it is possibly a lesion at the cerebellopontine angle affecting all these things, right?
The point is, are you going to say it's a tumor there? It's 10-day story. So what's the possible etiology? Cerebellopontine angle, yes. You got all that anatomy. Pathology, non-infective, non-inflammatory. So possibly tumor. But tumor in 10 days? No, hematoma. Injury. If he has had an injury, he has developed an hematoma in 10 days, no? That's not a tumor, but it's a space-occupying lesion. So do you think it's a hematoma? Or it's a tumor? Obviously, there is no trauma, and why should trauma just develop a cerebellopontine angle? It could develop a subdural hematoma or whatever. So it has to be a tumor. So tumor in 10 days, malignant tumor, right? Or benign.
So where is the catch in what sir is saying? Is he right when he says tumor in 10 days?
So that must be there since long, but like acutely increase in size.
So the clinical manifestation has come up now. It's not that the tumor started 10 days back or 11 days back, right?
One will again go back to the history and be sure that there is nothing suggestive of something going wrong for a tumor to come up. 10 days is too short for even a malignant tumor to come up. In which case, we only surmise that there must have been a small tumor without much symptomatology or without clinical signs, and that suddenly got further enlarged within 10 days' time. But the next question is, what can suddenly enlarge? Edema? So what do you think? What must have happened for it to suddenly enlarge? Only two things, right? Either an edema or a hemorrhage. Okay. Why should an edema suddenly come about that? Okay. For edema to happen, there has to be some reason, like a neurocysticercus. Okay, you start treatment with albendazole, suddenly there is an edema, and the child will throw up a seizure or whatever. So there has to be some trigger. If there is no trigger, there must be a hemorrhage. But more likely, that is not a common presentation. So small, subtle things probably might have been missed. And we go back to the history and say, did you think anytime you had a morning wake up and some headache or vomited occasionally or behavior was changed? Some small little thing there.
Tell us your examination findings. Patient is there. Okay. Get the patient. Okay, you can start reading your general examination, then we'll come to. Tell us your general examination. लाइए इधर लेके आई.
On examination, she was afebrile.
इधर इधर चलाओ.
इधर चला लीजिए, इधर आ जाइए आगे.
कुछ नहीं करेंगे ना, जरा ऐसे करके बताओ, आस्ते आस्ते हम साथ में आएंगे. आप साथ में रहो. हो गया तो नाम क्या है?
खड़ी रह सकेगी. आप बाजू में खड़ी रहो. बैठने पर सीधी बैठती है कि बैठने पर भी ऐसे होती है? ऐसा ऐसा होता है.
खाना खुद खाती है. हाँ, खाना हाथ से खाती है. इतना नहीं है खाना.
निगलने में भी कोई
खाना खाने में कोई तकलीफ नहीं होती है. बोलेगी तो साफ बोलती है या आवाज में बदली आया है? बोल देती. वेरी गुड.
So, sir, on a, child looks non-sick.
जोर से
आपका नाम क्या है?
जोर से बोल
Everyone, sorry.
She looks non-sick, alert, and speech so somewhat clear.
First, tell us what did you observe in the gate? Actually, you are senior. Let the others speak. No. Okay, go on. Go on. Speak. 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 Speak.
So,
What did you observe in the gate?
so there was some kind of circumduction kind of movement while walking. So most probably hemiplegic kind of case.
Okay, one. Anything else?
While walking, she was swaying more towards left side, I felt.
Yeah. So one thing that was very obvious was she was swaying. So she was not able to maintain her balance. Right? Okay.
even in standing position.
Fine. Okay. Now tell us what about your. You said non-sick. Then
Alert. She is alert, conscious, oriented to time play. Oriented to person. Her speech looks normal. Matlab clarity is there, and she could answer her name also. In other examination, like
now what can you observe? Just now.
there is obvious deviation of angle of mouth to left side.
Okay.
Moving her head to the left, looking towards left. So, sorry, right. Yeah.
Her weight looks to be less than expected, no? Correct? Yes, low weight and maybe okay, not much. So we are getting an etiology. What do you think about?
Possibilities.
So the disease must be silent for a long time somewhere, and now it's manifesting. Do you think that's the correct way of going about? The point is, she has a poor muscle mass, but not wasted. She has a reasonable subcutaneous fat, but not wasted. So this is her stature. I'm just trying to move you into that no, we will not call her sick. And therefore you should say she is not sick at all. If she is not sick, she has not a dissemination like a chronic illness.
Nystagmatoid movement. So vertical nystagmatoid movement is obvious. Eye blinking.
She's not blinking her right eye.
Right. Right.
So now examine to tell us whether there is a raised ICT. Because we said that there is a raised ICT. Examine and show whether there is really a raised ICT. You can maneuver the whatever examination you can do for raised ICT.
ICT, what will happen to the skull?
Open fontanelle in newborn.
At this age, will the size enlarge? No. Then what will happen? the pressure is trying to open the skull, which it will not. So size will not increase,
Furnish.
but something may happen.
Fundus.
A fundus examination we can do and papilledema will be seen.
Agreed, accepted. Anything else? Will the sutures open a little bit? Tend to open a little bit?
I was saying ki, looking for the extraocular movement. So third nerve palsy, if we can pick for it.
Simply asking what are the clinical signs of raised ICT. Forget the cause. Examination, what are the signs of raised ICT?
Brisk reflexes, clonus, elicitable. Then tone power. So the reflexes most.
So take one by one. What did you, one you said was
Reflexes will be brisk.
brisk reflexes. So you have to add something to that. Brisk symmetrical reflexes without affection of tone and power. You could have tone and power affection also causing brisk reflexes, no? So this, when it is due to raised ICT, then you have to eliminate local problems. Then what else? Without affection of power at least, not tone. Then what can happen to tone?
UMN lesion में hypertonia.
So
will be there.
there can be hypertonia. Then what other signs sir is asking? We are all tuned to symptoms, headache, vomiting. Sir is asking signs. So take one by one, more things.
Sustained clonus, well sustained clonus.
Okay. So that is one part of the CNS you have said, brisk reflexes. Now go elsewhere. So sixth nerve can be a sign of raised ICP.
Yes, sir.
But yeah, so we don't know whether this sixth nerve which we are observing is structural or raised ICT. That is one sign. What else? Which other nerve can get involved in raised ICT?
Third nerve.
Third nerve.
Okay.
So what will happen?
Diplopia, drooping of
No, sign. Ptosis and dilated pupil, no? Pupil will start dilating. So unilateral third nerve is often a sign of raised ICP. So you'll have to look at in the context, right? Then what else? General examination.
BP on higher side.
Very good. BP on higher side.
Cushing triad. So
Yeah. So Cushing's triad, of course, is late, but you will mention that bradycardia, BP high. Then anything else?
Mason.
Very good. Macevan sign. So chronic is Macevan sign and acute, she said, is papilledema.
Babinski will be in upper motor neuron region.
Largely, I don't think plantar extensor is a definite sign of raised ICT. Okay, it's not every raised ICT has a plantar extensor. Only when that tumor is causing also hydrocephalus, that you will have a bilateral pyramidal signs and a plantar extensor. That is number one. Second is these signs are massivans and the papilledema. They are these signs. The rest of them may be, may not be in addition, and that all depends on where is the tumor and what is it else doing to the thing. So signs are that. Cushing's triad is the end result and should never be seen by any one of us. It may be in an ICU rarely. So Cushing's triad is not to be mentioned really as a sign of it. Yes, it does happen, but that is at the extreme end of that. So that's not the normal thing. So you should say massivans and edema, papilledema, and also look for other things that we talked about, right?
Also, what he said is early is apedema, short duration. Massive ones may take a little more time for the sutures to open.
Discharge massivans and a papilledema, which means the problem has been going on for even more than 10 days. And that will tell us that It's a tumor earlier missed because of lack of symptoms or lack of observation or whatever.
Yeah, reflexes, you want to check.
Raised ICT alone is not a plantar extension. So now you have a bilateral pyramidal sign. So why should that happen in a cerebellopontine angle? As I said, hydrocephalus must be developed. So how can a cerebellopontine angle develop a hydrocephalus? Which part of the CSF pathway is obstructed?
So like SOL tuberculoma, so if there is concurrent basal exudate.
How does the CSF pathway go down from the lateral ventricle to third to fourth? There is a fourth ventricle there. No? So there is an obstruction of. In fact, as you go down to third and fourth, it's a very compact situation in the posterior, in the lower down cranial fossa, that multiple structures are there. And therefore, classically, cerebellopontine angle will have pyramidal signs, the cerebellar signs, the sixth nerve, the seventh nerve, and also hydrocephalus. So you're getting exactly an entire thing. But what is more important is all that tell us that this is not 10 days story, this is several weeks story. And therefore, we go back and said this must have started much earlier.
She wants to practice tone examination. तो उधर ऊपर ले जाके सुलाएंगे, इसको चला के उधर लेके जाइए और उस पे सुलाइए, इधर से चढ़ाइए ऊपर.
Are there cerebellar signs? Okay. So, all are there.
इस पे बिठा के सुला दिए सर इस तरफ.
In tone examination, passive tone and
Examine, you hold the mic for her.
so sir, in tone examination, in passive tone and active tone, in passive tone, we will inspect that how the posture looks like, whether it is hypotonic or hypertonic. So it's right now it doesn't look like hypotonic posture. And then also we will do a roll test and look whether that is a hypotonic feel. And at joint level, we will do flappability. So here we'll shake at joint level and we'll see whether it is moving a lot or like equal to our strength. And in passive tone, we will lift the knee and we'll see whether child is maintaining the same posture or it's falling down. So that will be, and if it is hypotonic, then we'll not be able to maintain the posture and will fall down. So it is this okay for passive tone examination or what?
So just one suggestion, when you do passive log rolling, as it is called, do of individual limb. And do both the limbs together, you should not do what you showed just now.
So like for ankle and knee joints, so I'll do here.
Correct. So left and right should be done separately is what I'm saying.
Okay.
Yeah. Not roll both of them together.
And then in active tone examination,
Also, no, sorry, 1 minute. In passive, while checking passive tone, the easier thing is to see whether you can pass your hand under in the popliteal fossa.
Hmm.
So if you are able to pass normally, that means a normal tone. If you are not able to pass, then you will say it is hypotonia because the leg is lying flat against the surface. And if it is hypertonia, then there might be like this. So there'll be a little extra gap underneath. Similarly, when you say about the posture, then if it's the toe is pointing straight, then it's normal. And with hypotonia, you might get
plantar.
correct. So that will depend on the tone. Hypertonia can also give you plantar flexion, depending upon whether the gravity or anti-gravity, which muscles are stronger.
Then in active tone examination, we will do slow movement.
Active tone.
So in active tone, we will do the fast and the slow component. So initially we will go fast to look if whether it is increased, and then slowly we will do same movement. So whether we feel any catch or this. So right now I'm not feeling any catch, so not like hypertonia.
So it's a normal tone. No hypertonia, no increased tone. So it's a normal tone, right?
It looks like normal.
Would you try? Because we have a plantar extensor, so we need to pick up if there is a mild spasticity. Okay. Would you try examining?
When you examine the tone, try to isolate the joint and yeah. Try to isolate the joint. So when you're doing this, suppose you are doing this, then don't do this. Okay. Keep this here and then try to straighten it. And then okay. So as we mentioned, try to isolate, fix the proximal part and then you extend. And that you do once or twice, you do slowly with the same speed throughout to see for hypertonicity, whether it is cogwheel or lead pipe. You want to do spasticity, then you do a fast movement. So then you will get the catch and then you will know whether there is spasticity or not.
In the lower limbs, the adductor spasticity is most prominent. So you should look for hip adduction as the first step. So as sir was saying, you look for minor signs. So first you should look at hip adduction, whether that is affected. And I think when the left leg was being checked, there did seem like a catch. Yeah, so there was some evidence of spasticity on the left side, right? Okay. Yeah, tell us your findings.
On examination, she was afebrile, pulse rate of 90 per minute, respiratory rate of 20 per minute, Pulses were well felt, extremities warm. BP was 92/60, which was at fifth centile. Pallor was seen. Subcentimetric bilateral lymph nodes, no icterus, cyanosis, clubbing, or edema. Anthropometrically, weight lies between -1 to median. Height is 123 centimeter, median to +1 standard deviation. She is normal by anthropometry. BMI is 13.7. On head-to-toe examination, head shape size looks normal. Eyes had vertical nystagmus. Along with that, there was a ptosis seen in left eye. Ear, nose appears normal. Extremities, spine, genitals normal. BCG scar was seen. On systemic examination, CNS examination, higher mental functions were intact. She was conscious, oriented to time, place, person. Attention was intermediate. Memory, immediate memory was intact. Recent and remote memory, child could not tell us.
So
Intelligence.
can you give examples of all three? Immediate, recent, and remote. What did you ask?
Immediate memory, we can ask the child she's 7-year-old, so she can tell us whatever I had spoken to her. Like if I say a word, I can ask her to repeat the same word. Or if I tell her a spelling of a word, I can ask her to repeat that spelling. Recent memory, we can tell her 2-3 words or 2-3 numbers and ask her to repeat in reverse order. And remote memory, we can ask her where she stayed, ask her what was her first school name or her birthday, or if she has changed her home, so where she had lived previously.
I think in recent, we can also ask her what she ate last night or what did she have breakfast in the morning. So little bit behind, but yet recent. Okay.
Speech, fluency, comprehension, and repetition was intact. Cranial nerve examination. First cranial nerve had no abnormalities. Second, gross vision was intact. Fundus was no abnormality detected. Pupillary reflexes were present, and she had vertical nystagmus in bilateral eyes. She could not follow fingers in lateral directions. Direct and consensual light reflex were present, and she was unable to look at the nose. So. Ocular movements were affected. There was also fourth cranial nerve involved.
Fourth.
Third, fourth cranial nerve. Fifth was intact. Sixth, she was unable to look laterally, bilateral eyes. And seventh, there was deviation of deviation of angle of mouth to left, unable to close right eye completely. No wrinkles were seen on forehead, unable to blow. Sensory component was intact. 8th and 9th nerve was intact. 10th and 11th, 12th nerves were intact. Motor examination. Motors, there was no visible wasting. Tone was
It was all normal.
initially normal, sir.
No wrinkles on the upper part, no? So it's the supranuclear. Only lower half is involved. And we have been talking about the nuclear lesion, isn't it? You get my point? Just go slide before that. No.
Seventh, no.
Seven now. No wrinkles on forehead.
Right side.
No wrinkles on forehead is
కోర్స్
element.
ఎస్టాబ్లిష్ చేసింది అయినా అనమాట 85 years
No.
90,
So,
85
yeah, no wrinkles. I thought they had seen the wrinkles.
ఇంకా డెడికేటెడ్ ఉంటారు అబ్బాయి
Power, neck flexors and extensor was 5/5. Shoulder joints, all flexor extensors, abductors were 5/5. There were hip flexors.
Can all our viewers mute themselves, please? If they're not speaking. Jala Chandana. Mute yourself, please. Okay.
The left side of hip flexors had 4/5 power. Then hip extensors 4/5. Knee flexors left-sided were affected. Extensors also. Ankle and so her lower limbs were affected. Hip also left-sided. And bilateral knee were brisk. Ankle 3 plus. Biceps and triceps were 3 plus. Superficial reflexes were present and plantars were upgoing. Test for coordination. She was unable to perform finger nose test. Stands and
Means
gait.
unable to perform means.
There was pass pointing.
So you should not write unable to perform. It doesn't give us the correct picture. So you should say that in finger nose finger test there was
Pass.
considerable pass pointing.
Unable means either she was not able to raise the hand,
Means
or
it
she-
gives an impression of paralysis of the hand
or she
or
didn't understand what you said.
Gait, ataxic gait. Sensory system was intact. She had pendular knee jerk and tandem walk was not possible and she swayed bilaterally. Meningeal signs were absent. Other system was within normal limit. Impression: 7-year-old girl, case of acute onset bilateral horizontal gaze palsy with lower motor neuron type of facial palsy with left-sided paresis with cerebellar lesion with signs of raised ICT in a birth and developmentally normal child, probably is a case of space occupying lesion to rule out tuberculoma or meningitis, malignancy.
so you said bilateral sixth now. So are you suggesting that there are multiple lesions?
On examination, sir, she was not able to look laterally by both sides.
That's
So
what.
bilateral.
So which means you're saying bilateral sixth now, right?
So she had tumor in left side as well as right side cerebellopontine angle,
Could be in midline.
midline. Anything else can happen? Can one of them be false localizing?
Could be.
And both be false localizing.
She has some signs of raised ICT, so could. Uh,
So how do we explain right-sided cranial nerve involvement with left-sided pyramidal tract signs? You showed us left-sided pyramidal sign, right? Weakness at least, if not reflexes. And we thought the left side tone was slightly increased by it. So right-sided cranial nerve, left-sided pyramidal tract.
Because pyramidal tracts cross.
Very good. So say that. What is it called?
Cross hemiplane.
Crossed hemiplane. Very good.
Her MON2 was positive, around 12 mm. CBC was normal. We had done her CT brain, so that we have a
Sorry,
provisional
can you
report.
just go back one thing? Something is bothering me a bit, so I want others to clarify, sir, to clarify. You mentioned bilateral sixth nerve palsy, and you also written bilateral horizontal gaze palsy. Right?
And she had vertical nystagmus.
No, vertical nystagmus is fine. So what is the difference between lateral gaze palsy and lateral rectus palsy, giving rise to inability to look on the left side? Say it, it's okay. All of us are learning. There is no problem. Say it, it's okay.
Lateral gaze palsy, I had written by mistake. Means child would not be able to look laterally, but in our patient.
That's right. So when a child to look on the left side and both the eyes are not able to go on the left side, then you may suspect it as left lateral gaze palsy. if there is a left one-sided lateral rectus palsy, that eye will not go on in that direction, but the other eye will still try to go in that direction. So that is how you differentiate between gaze palsy versus the muscle.
So gaze, as Tushar said, is conjugate gaze. That means both eyes have to go together in that direction, as against a one eye ka muscle paralysis. The two things are different. That's what he was trying to say.
CT brain was suggestive of large peripherally enhancing well-defined hypodense lesion within the fourth ventricle, extending into the right cerebellopontine system. Could be a giant interventricular tuberculoma. They are given more likely than epidermoid cyst, and there was mild prominence of bilateral lateral ventricles and third ventricle. Some query vasculitic infarct in the right corona radiata also. So AKT had been started for her with the steroids. Today MRI was done. Reports is of it. Yes, sir. I had not put here, but it was not.
You'll be doing a biopsy. Tuberculoma versus malignancy. No? How will you settle that issue? I suppose biopsy.
In India, tuberculomas are more common, and malignancy, she would have been more sick.
Because your MAN2 is positive, it is tuberculoma?
MON2 does not. If MON2 is positive, it just suggests that a child can mount, her immune system can mount.
Your answer should be that you will look for an evidence of tuberculosis in the body. You don't have to go down there for that. And MAN2 is of no use. So MAN2 positive or negative doesn't help. So look for chest, maybe if there's a possibility of even bacteriological diagnosis, molecular diagnosis. So look at that lymph node somewhere. Pick up something that is possibly giving you an idea. Finally, if you cannot, then the question is, what do you do there? Then you treat as tuberculoma and follow up to see what is happening. Okay. And that's the only way to go about. Now, would you be giving a steroid also? Anti-TB treatment is fine, but steroid.
For CNS, it is an indication to start steroids.
And
CNS
therefore,
tuberculosis.
very likely, looking at the seriousness of the problem, looking at this has been going on for some time, malignancy is less likely. Therefore, we will go by taking it as tuberculoma and follow up to see whether there is any improvement at all.
I'm sure if available, affordable, one would think about getting an MRI brain in this patient, because that will have certain features to differentiate between tuberculoma and an epidermoid cyst or any other SOL. Also, when you do MRI brain, one could ask for MRI spectroscopy along with that, because then they can pick up those lipid peaks in the surrounding area, etc., and can get a better non-invasive differentiation between the two. The whole point is, if it is not a tuberculoma and an epidermoid cyst, then waiting may not be the ideal thing. Operability or inoperability will have to be decided.
Only one lesion, there are no other lesions.
So if you say there is a CSF density in right corona radiata with query vasculitis infarct, then definitely epidermoid cyst goes down on the differential and tuberculoma goes high up on your differential. But that's a corroborative evidence, so one would not rely on that.
Looking at the lesion coming in the ventricle, in the fourth ventricle first, and then extending down that, I would expected the signs of IC to come a little earlier and paresis little later, because that would obstruct the CSF a little earlier. But here, I mean, it's more or less at the same time, you can say.
So if you're presenting a case which you are very nicely presented, you're talking about a CP angle involvement, then please talk about neurocutaneous markers. don't miss out on that. And second is talk about vestibular or cochlear affection. So hearing test, etc., would also feature in your different diagnosis. Not with tuberculoma, but if it was
Fine, okay. Thank you. We'll have a second case. स्क्रीन शेयर कर पहले, इसको मिनिमाइज कर. मिनिमाइज कर वो. जूम को बड़ा कर, जूम का विंडो बड़ा कर.
Uh, 1 year 9 month old female child, third by birth order, born out of non-consanguineous marriage, residing at Nala Supara, basically hailing from Prayagraj, UP, brought by and informed by mother, complaining of periorbital puffiness since 3 days and decreased urine output since 2 days. Patient was all right 3 days back when mother noticed that patient having periorbital puffiness, which was sudden in onset, gradually progressive in nature. It was actually more in morning, and as the day progresses, the swelling decreases. Uh, Gradually, that swelling has involved face and all over the body. Decreased urinary output since 2 days. It was decreased in frequency of the urine as well as the quantity of the urine. For this complaint, she went to the private practitioner, and that private practitioner has given some medication, but the swelling was not resolved. Hence, the patient was referred to Sion Hospital. No history of breathlessness on exertion or chest pain or any recurrent chest respiratory infections. No history of jaundice or blood in vomitus or blood in stools. No history of reduced weight or failed to gain weight. No history of cola colored urine or headache, blurring of vision. No history of fever, skin rash, or history of any drug intake. Or no history of cellulitis. Past history is not significant. ANC history, mother was registered and she had routinely visited to the for ANC checkups, and 4 ANC scans were done, which were told to be normal. She has received iron folic acid and TT injections. No history of thyroid or no history of any thyroid problem or anemia or hypertension. No history of birth history. It was a full-term normal vaginal delivery. Birth weight was 3.7 kg. Baby was cried after stimulation, back stimulation. No history of an ICU stay or neonatal jaundice. She was started on breastfeeding after 1 hour of delivery. Dietary history: she is deficient in calorie by 170 kilocalorie, and uh, and deficient for protein for 2 grams, immunized till date. Developmentally, she walks unsupported. She runs but falls after few steps. Fine motor scribbling were present. She can pick up the cup or spoon but without spillage of the food. Social history, she does mimicry of the parents or any relative. Language history, she speaks 4 to 5 words with a meaning. Family history is not significant. On examination,
Wait. Come here, we'll discuss for some time. So, what do you think, Manas, from the history?
Periorbital puffiness first complaint. So, so renal causes we have to look for. Uh,
So, why renal causes? Why not an eye infection?
uh, it's not mentioned, but I guess it's bilateral.
Good. So, bilateral rules out a local cause or makes a general cause more likely. Then,
Is also there is variation. It's decreasing in the evening.
okay.
And,
So, why renal? We've discussed this many times. No, you should give a good logical answer in the exam. Okay, why renal?
onset also
Onset is
very acute, like in 3 days, unlike in other causes where cardiac and GI causes, the swelling could the onset could have been more gradual, more days history.
yeah. So you're right, but you have to understand this properly. When you say onset is gradual in cardiac, means even in cardiac, patient is going to notice edema one fine day at one fine time. No, in patient will say that Sunday morning ko edema dikha. So it is acute only. No.
But
So
on the
what is that gradual?
other associated history for cardiac, so difficulty in on exertion, there is difficulty in breathing.
Very good.
All
So
this,
exertional dyspnea,
dyspnea.
maybe palpitations, maybe other symptoms, effort intolerance, whatever. So there is a long symptomatology. What about other causes?
Same for GI causes, all symptoms of like of liver dysfunction, so sick, not growing well, uh, jaundice, bleeding manifestations.
So now you put the same thing reverse. So you say that when there is a absolutely normal healthy child who suddenly comes with bilateral puffiness, which is persistent and progressive. Persistent means not a one day affair and gone. Is there one day, next day, and is progressive with this diurnal variation. So that makes it renal in origin, right?
Yes.
Then within the renal, can you further quantify, sort of define the anatomy? So is it glomerular? Is it tubular? Is it, what is it? So in the kidney, which are the anatomical parts of the kidney which can give rise to proteinuria?
So glomeruli and uh, tubules.
And then the third part is the collecting system, like the pelvis and the ureters. So which one cannot give rise to proteinuria? Tubules.
Tubulars.
Tubules or pelvis and collecting system?
Collecting system.
Fine. So clinically, how do you differentiate between glomerular proteinuria or tubular proteinuria causing edema? If a patient comes with edema, how do you know which one is it? Okay. First, okay, who can go on?
Glomerular proteinuria and tubular. So
What is the word for tubular proteinuria? There's some special word
Tom's House.
that I have forgotten, but I was looking for something else. So it's microalbuminuria, or so therefore tubular proteinuria does not have clinical manifestations of edema because the proteins that are lost are low molecular weight. That is one. How does tubular disease present clinically?
Hematuria.
Tubular disease. Give an example of tubular disease. RTA. So how does RTA present clinically?
Metabolic acidosis, urinary loss of glucose, amino acids,
So symptoms, clinical symptoms.
metabolic acidosis.
Yeah. So acidosis in the sense symptoms will be polyuria, failure to thrive, occasional vomiting, growth stunting, all these things, right? Those will be your symptoms of tubular diseases. What about glomerular? Very good. So there can be hematuria depending on within the glomerulus, where is the problem. Okay. So within the glomerulus, you can further subdivide it into epithelial disease, endothelial disease, and interstitial disease, right? So depending on where is the problem, you can have additional hematuria. What else? Proteinuria is as edema. It's from edema that we started on proteinuria. Any other symptoms? Clinical manifestations of glomerular disease.
Hypertension.
Very good. So hypertension, of course, it will be on examination. Then, very good. So oliguria. So oliguria is a marker of reduced glomerular filtration.
I think once you say glomerular, you add a word glomerular endothelial or epithelial. Okay. So epithelial has much more severe edema. The prototype is nephrotic syndrome, whereas a typical endothelium is a mild edema, often oliguria, hematuria, hypertension. But this is very microscopic difference. One gets on to another area as well. And one can start with one area and spread to the other. The point I'm making is, therefore, is this a glomerular endothelial disease primarily or glomerular epithelial disease, which is almost having also some reduction of urine output and therefore an endothelial involvement? You might see hypertension as well. You might see microscopic RBCs as well. So do you think onset is endothelium or onset may be epithelium? One is like an acute glomerulonephritis, post-streptococcal, post-viral, whatever. Another is like nephrotic syndrome. So I want you to guess at this level only whether we are looking at one or the other. Give a thought to that.
More probably epithelial disease in origin, because first manifested and noticed edema, and then that was of epithelial involvement, and till now hematuria, hypertension, that will be gradual. So prominently we got edema. So I think it is epithelial in origin, sir.
Point that I want to make is at this point of time you would have asked some more questions. And what some more question? Has there been any fever in the recent past? Okay, that might push it to say it's like a endothelial disease. Or this child has been absolutely normal and suddenly developed. So this is one. What is the age difference between these two types of lesions? Which is more common at this age, endothelial or epithelial? In other words, nephrotic syndrome is more common at this age, or a glomerulonephritis is common at this age. Both can occur at any age. Okay. And therefore, likely nephrotic syndrome, but not necessarily not nephritis. Really, nephrotic syndrome is also nephritis. It's an itis, it's an inflammation, but one having more of a filter problem and therefore large proteinuria, another more like an GFR going down and therefore a low urine output. But two can overlap a great deal. But if he was very healthy and suddenly developed, more likely nephrotic. Nephritis at this age is not common, but certainly can occur. And therefore you would have asked for a recent fever. Okay. You know, post-streptococcal glomerulonephritis, but 2 weeks earlier there was some streptococcal infection. But that's typical. Any infection can cause it. Now I'll give you a situation. He said, just 2 days back he had fever, but now from yesterday there was no fever, and now he has developed edema and oliguria. And mild fever is still there. Is that a possibility? What kind of possibility? As I said, typical glomerulonephritis post-infective is a gap between fever and the manifestation. Here, it's almost overlapping.
IgA nephropathy can come with.
I want you to take a note that dengue fever will present like this. Oliguria and edema. Of course, child will be looking sick, almost getting into that. And therefore, if this child was absolutely normal, it's a nephrotic syndrome, even when there is now. Now look at what you have really earlier said in the thing, that gradually increasing or something. The word is gradually increasing. No, yeah. One said gradually progressive in nature. So when you talk about gradually progressive, we are talking about not very few days, but probably more number of days or a week or so. So could be that. We are not sure at this time.
On on examination. Okay. On examination, child was lying on left lateral position on bed. She was febrile. Pulse rate was 112 per minute, which were regular in rhythm with good volume. Respiratory rate was 36 per minute. Peripheral pulses well felt. Extremities were warm. Saturation was 99%. BP was 100 by 62, which lies in 90 to 95th centile. Bilateral lower limb edema, pitting edema was present. No pallor, icterus, jaundice, lymphadenopathy, clubbing or cyanosis. Anthropometrically, she was height was light between -2 to -3 standard deviation, which makes impression as a stunted. Head to toe examination.
Just we'll, I think we'll just quickly look at the child from a distance
Yes.
and then let them go. Come on, somebody observe and tell it. बस ऐसे ही पकड़ के बैठो रोएगा कुछ नहीं करते हैं बेटा. Just examine in the light of what we have discussed.
Child is comfortably lying on mother's lap. On examination, mild periorbital puffiness is there.
Sick or not sick?
Not sick.
Okay.
Not
Growth,
sick.
growth.
Well nourished.
Okay.
Healthy child.
Healthy child.
No edema.
Mild
There is a mild periorbital edema.
Even dorsum of
Even
the feet.
dorsum of the feet. So then it's not only there, it's somewhere else.
Abdomen also probably is this.
Okay. So diagnosis.
Nephro.
So diagnose nephrotic syndrome. But first attack, nephrotic syndrome is often repeated, no? But this healthy child, happy child, comfortable child, multiple places, edema collection, very likely. Now add to that hypertension coming up, okay, going towards that. So all that is a nephrotic syndrome till proved otherwise, right?
अभी अच्छा है ना पहले से? ये पहले से.
Likely to be a chronic liver disease. You have an abdominal distension, you have an edema, chronic liver disease.
Just like the symptoms are acute in onset.
No, but chronic liver disease also will have all that, no? Abdominal distension, edema.
No signs of liver cell failure. No interest.
No bleeding manifestation. No bleeding manifestation.
Yeah, so no signs of liver cell dysfunction. What else?
That is no interest.
Is non-sick.
Very good. So growth is normal. So a chronic liver disease which manifests with hypoproteinemia must have a suffering of growth in the last few months, years. So that's why no chronic liver.
But the height is -2 to -3 SD and weight is 0 to -1. That weight is because of the edema. You take the edema away, he will also fall into -2 to -3 or maybe even lower. Right? This 9.9 is with edema, isn't it?
So how do you explain that? 1 year, 7 months. How much? 1 year, 9 months. How do you explain what Tushar is asking? That if you take out the edema weight, then this child has both poor height and poor weight. So there is growth failure. So then it can be liver disease. Can you explain that?
We have to see the weight by height, and that should be less than. The weight and height will be equally affected if we take out the weight and see the actual one. So weight and height is equally affected, then that is not chronic systemic illness, so less likely liver dysfunction.
Add one word that if weight and height are similar centiles, it's likely to be constitutional. and then she didn't look sick and all that. So you'll have to maybe even pick up old readings and show that she's always been on that curve, right? Okay.
Head to toe examination.
Dr. Sen Gupta, can you please mute? Dr.
Yeah.
Sen Gupta,
Head to toe examination. Head was normal. Face suggestive of bilateral periorbital puffiness and facial puffiness was present. Neck was normal. Chest normal. Genitalia was labial swelling was present. Spine normal. Hair and skin was normal. Systemic examination or per abdominal examination on inspection. Uniform distension of abdomen was present. Umbilicus was central. No dilated veins, scar, or sinus seen. No visible pulsation or peristalsis seen. On palpatory findings, inspector findings were confirmed. On superficial palpation, uh, it was soft and normal temperature. No guarding rigidity or tenderness was present. On deep palpation, liver was just palpable. Abdominal girth was 44 centimeter. No splenomegaly. On percussion, shifting dullness was present, and on auscultation, bowel sounds were present. Other systems were normal. Summary was 1 year, 9-month-old child, third by birth order, born out of non-consanguineous marriage, presented with bilateral puffiness, bilateral periorbital puffiness since 3 days, which was progressed to face, abdomen, and then all over the body. Suggestive of renal etiology, most likely the first episode of nephrotic syndrome in a birth and developmentally normal but stunted child who is immunized till date.
okay. So how will you investigate this child?
Some uh,
Yeah, would have been better if you had mentioned that the abdomen was more bulging at the flanks.
hmm. So starting with CBC, LFT, RFTSC, uh, and spot urine albumin test. Then urine routine microscopy, chest X-ray.
So spot urine albumin means protein creatinine ratio, you are saying, no?
Yes, sir.
Okay. Why do we do that?
Glomerular range proteinuria, you have to check.
So it is a indirect marker of what? Protein creatinine ratio is done to do what? Quantification of proteinuria, na? So you would otherwise do a 24-hour urinary collection and then see how much protein is excreted over 24 hours. That is difficult in children. So you do a spot protein creatinine ratio, which gives you the same information, right? Okay. Show us the investigations.
So
Not done yet.
we have done, but I have not.
Okay. You know anything orally?
RFT was
Urine routine.
3+ protein is.
Okay. And ratio has been done, protein creatinine ratio.
Ratio was more than 2, sir. Actually, urine protein was 2000 and creat was 171.
Okay. Fine. And you thought that the BP was on the higher side. So what is the significance of that?
We'll have to monitor, keeping in mind nephritic syndrome also. And if routine microscopy of urine shows RBCs, hematuria, then that would suggest nephritic syndrome, edema, hypertension, and yeah.
Did urine routine show any
No,
RBCs?
no RBCs were
Oh.
there.
How will you treat this child? How will you treat?
Initially, we will rule out so we will see for focus of infection that precipitate. We'll treat that acute infection and we'll start on steroid. So for
How will you see focus of infection?
concurrent symptom child is having,
So this child is not having any other symptom.
then complete blood count and
So means
X-ray.
what I'm saying is, while your concept is right, but tailor your answer to this child. So in this child, there are no other symptoms, so you are not looking at any other infection.
We'll start, so we'll do one chest X-ray to rule out concurrent hilar lymphadenopathy or COX that is more common in our country. And then we'll start him on a standard dose, standard protocol. So predni at the dose of 2 mkd or 60 mg per square meter for 6 weeks daily. And then for 40 mg per square meter on alternate day for next 6 weeks. And we'll see for resolution of resolution of proteinuria symptom.
I don't know whether we should ask that, has the disease been present only for 3 days, or the edema has come only in 3 days? So what is the pathogenesis of edema? That means he has been normal 3 days back and all the protein is lost in 3 days. So edema has come up in 3 days. Is that so? If not, then what is, apart from hypoproteinemia, is there any cause for genesis of edema?
Malnutrition.
In this
Protein.
particular child. So what is the pathophysiology of edema?
Change in that osmotic and hydrostatic pressure.
There are those two theories about the edema.
Underfill and overfill theories.
So we'll have to go a little bit in details of those theories because you may be asked about them. But certainly the disease proteinuria has been there for a longer time, not now. But the edema has come up abruptly, not albuminuria. Hypoalbuminia has been there for quite some time. And another point which is not related but concerned with orbital edema, the two things to be considered. One is unilateral orbital edema and not the others, which is indicative of a sick child because it may be secondary to ethmoid sinusitis, and only upper lid edema and no lower lid edema at all is suggestive of a lymphatic obstruction due to even a minor looking scalp infection. Here, of course, when you say bilateral, upper limb, lower limb, all orbital, everything is involved.
There is a hypertension, right? Diagnosis nephrotic syndrome. Are you planning to give steroids? There is already hypertension. So I would wait for the blood pressure to come down and then start steroid. How do you like it?
Sir, because of disease pathology, that must be the manifestation of hypertension, like glomerular damage and.
No, I don't understand whatever the cause of hypertension in this child, yes. But the point is, when you give a minimal lesion nephrotic syndrome or steroid, by the time 2-3 weeks have gone, you start monitoring blood pressure. And if the blood pressure has gone up, you reduce steroids or you may have even to omit it and first treat hypertension. But this child is already on the verge of hypertension. So are you going to start steroids on this?
So sir is asking that because there's hypertension, do you want to not start steroid? Is it a limitation to starting steroid is what sir is asking.
So as far I think कि for first episode we will have to start on steroid. So if it is persistently on higher side, then we will give simultaneously antihypertensive and we
Good. Will you use diuretics in this child?
he has
Fluid retention in a hypertension, the drug of choice is diuretic. And he has exactly that. How can you not give diuretic?
Volume is actually depleted in nephrotic.
So the point is, when hypertension is significant and a fluid retention is a milder issue, you can choose a diuretic, but not in this child. In fact, this child he has already got an intravascular constriction. There is an oliguria, and then it will add up further. So you will, and diuretic is almost never required for a nephrotic syndrome.
Any questions from your side?
So I wanted to ask how we will counsel the patient first child like that SOL. So if her mother asks regarding prognosis.
The first patient. No, we said that the findings like suggestion of increased intracranial tension, number one, okay, indicates that there must have been some time lapse before that happened. Now that is number one. Second is he has already made a mention for tuberculoma, the infarct goes in favor of tuberculoma, and therefore infarct can happen suddenly. TBM can happen suddenly in a short time, but there is something happening before that. So this child obviously has had some more days of suffering, which is often missed. And we need to ask in details whether there is no doubt that this must have gone for some time because there is no complication that suddenly occurred. In a typical malignant tumor, suddenly an hemorrhage is known and a sudden manifestation may occur. But even then, in tuberculoma, that doesn't happen. So there must have been some milder form of an illness. And the illness could have been a silent illness, but at this age, it's not silent illness. So one other issue is that if this was a smaller child, younger child, he would not have presented like this. He would have presented as a TBM with or without tuberculoma. But here is an older child. So that silent infection has spread, but even spread is localized. Even then, the CSF might show some pleocytosis or might show some increased proteins, indicating that there is already some meningeal inflammation, and that might again go like an infarct in favor of tuberculosis. So this is not 10 days old illness. This has been a silent illness, silent as far as mother reporting to you, and maybe at that time a clinical examination might have picked up a plantar extensor or a little paresis of the eyeball, so something. And that is what the conclusion is, right?
Sir, she wants to know also how to counsel that parent.
Counseling is not difficult. We would say that your child is now diagnosed as having some mass in the brain. And we want to consider whether that can be treated with medicines only. And we are trying to do that. Very likely we will be right and we will succeed. However, we need to keep in mind how the drugs acts, because it could be for all that you know drug resistant TB as well. So we would say that mostly this child will respond, but I will also look at any obvious contact as another evidence of a tuberculosis, and then say that this child could have had tuberculous contact anywhere outside in the community because your family doesn't have, obviously. And therefore, our impression is that we are likely to meet with successful control by just medication. However, we'll have to watch for the next 2-3 months to be sure that the medicines are working. And because we hope they will work, we are not proceeding any further right now. However, if the symptoms continue or a new symptom arises neurologically, you should run back to us and we can take care of it. That's the way we would go by, right?
Okay. So I think with that we stop. Do our online friends have any questions? Anjali, any
Yeah,
comments from your side?
I had a question. I wanted to know how much to chase tuberculosis. Should we do gastric lavage? Should we do CT scan of the chest or abdomen to find a primary lesion somewhere else?
So gastric lavage for sure. And she said the chest X-ray was normal.
No,
So
I
I
wanted
would
to
do.
know whether a CT chest would be a better yield in your experience. In what about sir's experience or?
So, sir, Anjali is asking whether you would do a CT chest in the first child to look for tuberculosis elsewhere.
I think theoretically you can do that, but practically a normal chest X-ray, no symptomatology at all. Okay, and a manifestation which is more of a immune-mediated manifestation that is also local. And to that extent, I won't really push myself to CT, but yes, if you say, could CT pick up something? My answer is yes, it may be, but possibly not in this situation. So that will be my way of looking.
Okay, thank you, sir.
Dr. Anjali, my two bits on this. I would
Chest CT.
definitely go for even family screening at length and
Okay.
chase by way of MRI, as I already mentioned,
Yes,
in order
spectroscopy.
to classify or characterize the lesion in the brain.
Yes. Yes. Thank you. Sir, today we had 25 viewers and they were down to 19, 20 by the end. Last week we had 15, which were down to 10 by the end of the session. So this week we have added more viewers.
Yeah, good. Very good. I think the news is spreading. So
Yes.
good that we are getting more and more people joining in.
And today,
Anyone else has any other questions or any comments? Yeah, Anjali, you were saying something?
the audio was excellent.
Okay, good. Chalo. I think we have sorted the audio issue at least. Now let's hope it works every time. Okay. Thank you, everyone.
Thank
And
you,
we
sir.
meet
Thank you,
once
everyone.
again next Thursday. Thank you.
Hello.